every time you keep someone intubated because you're worried about extubation or you don't have a good extubation strategy, you're increasing the risk of delirium, the risk of infection, potential other complications. And those are also minutes, hours, and potentially days that you're sort of preventing that patient from interacting with their loved ones and their friends, family, and what have you. So it's a big deal.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And I'm your other host, Dr. Cyrus Askin. Nick, it's great to see you back stateside. How are you and the family faring after your gallivanting through Europe?
Yeah, no, it was a fun adventure. We had like a week of the kids waking up at like 2 a.m. So, the little jet lag issues, but first world problems.
Sounds like my life right now, actually, with the 3-month-old. So.
Oh, yeah, that's right. I joined your world for a few days.
Yes.
I was a little afraid that my tweeting would get me stopped at the airport, but I made it past customs, no problem.
Well, so I'm glad for you. I'm glad that worked out. I'm glad for us, I suppose, and for our audience.
Yes.
Well, Nick, now that you're back here with us in the good old US of A, that must mean we have a fun and exciting topic to discuss. And what might that be?
We sure do. So we've had several episodes talking about intubation, putting those endotracheal tubes in. I think it's finally time that we have an episode where we talk about getting those tubes out. So let's do an extubation episode.
Nick, I think that's a great idea. And, for our listeners out there, this is a topic that's been requested by a few different folks through social media. So we are very excited to finally be getting to this. We've got a ton to cover. So why don't we just go ahead and get to it?
Let's jump into it. So I think, first off, we should just acknowledge something, which is that we talk a lot more about intubation than extubation. As a critical care community, we have many, many episodes of podcasts and shows about difficult airways and things like that, but we really don't have any content which is about the difficult extubation, and I think that's something we should try to fix here.
I think that's a really good point, Nick. And, we focus a lot on all of the nuances and intricacies related to intubation, but I think we often just as a society, as a critical care society, don't really dedicate enough time and mental energy to the process of extubating our patients.
Yeah. And I think, it's a big problem. I mean, if you want to quantify it, which I did, you can do like searches on PubMed, and there's roughly 5 times more articles about intubation than extubation. There's like 100,000 intubation articles and less than 20,000 about extubation. There's also a ton more FOAMed. So I found like 3,751 podcasts with intubation in the title, but a scant 535 about extubation. So I think, we're kind of amplifying this discrepancy by making a lot more content about tubes going in and a lot less content about tubes coming out.
Yeah, I guess we're part of the problem too, because we did have those 2 episodes on difficult airways. I'm sure we're going to have some more, and here we are just having the 1 episode on extubation. But hopefully it'll be a doozy, because I know that
we'll just make it really long.
We'll make it super long. Yeah, so 6 hours from now we'll be wrapping up. I think that in the same sense that you can have a difficult intubation, and that certainly deserves some time and discussion, you can have a difficult extubation. And so I think one of our goals for this episode, one of our big goals, is to tackle some cases a little later on where we go through those situations where maybe the intubation was a walk in the park, but the extubation is where you're getting all your heartburn.
That's a great point. I think we should popularize the term difficult extubation and kind of normalize its use, because I think that's a great framework and a great setup for our discussion.
Love it. All right. So I think we set the stage pretty well. Maybe we can sort of outline for our audience clearly why we're doing this, other than to try to sort of buck the trend in our small way that we can on this podcast.
Yeah. It's a great setup. So why is it so important to have this conversation? Well, I mean, I think liberation from mechanical ventilation is one of the most important decisions that we make in the ICU, and delays or failures in extubating prolongs critical illness and thereby exposes our patients to a lot more risk.
Yeah, I think that's a great point. We're going to get into this a little bit later, but yeah, every time you keep someone intubated because you're worried about extubation or you don't have a good extubation strategy, you're increasing the risk of delirium, the risk of infection, potential other complications. And those are also minutes, hours, and potentially days that you're sort of preventing that patient from interacting with their loved ones and their friends, family, and what have you. So it's a big deal.
Yeah, they can't speak, they can't eat, and they have limited mobility, which, we've had several episodes talking about that. I think, this isn't just because people are bad doctors, though. Determining readiness to extubate can be challenging. There's a lot of factors that interact. I think many people have this misperception that extubation is about when the lungs are working. But in reality, extubation really requires anticipating and solving a lot of problems that are all kind of overlapping. So for example, like the underlying illness, is it getting better? Their mental status, are they awake and responsive? Can they follow commands? Secretions, are they able to pulmonary toilet? Cuff leak, is their airway swelling? Respiratory mechanics and work of breathing, are they strong? Are they coordinated? Hemodynamics, can their heart and cardiovascular system tolerate this? And then finally, lung function, are their lungs working? And so, it's kind of like everything has to work right in order for this to succeed.
I think those are great points. I think maybe we've uncovered the first area in all of medicine where we disagree, and that's the term of pulmonary toilet, which it really grosses me out. I try to stick with airway clearance, but I know that that's like a long-standing term in the lexicon of critical care. So I'll give it to you. I'm not gonna fight you too.
I'm gonna try to use it like 10 more times in this episode.
Yeah, great. Yes, you're so triggering. It's like you go to Europe and you come back, and now you're just trying to rage against the machine.
I think it would be toilette.
That's right. That's right.
Pulmonary toilet.
Somehow that sounds worse. I don't know. Anyway, so great. So pulmonary toileting notwithstanding, great points on, I think how complex this is, how dynamic this is, and, a couple other just concepts that I think are worth putting out there into the ether is, in general, it's better to try and fail than to not try. And I think we're gonna touch on this specifically in the context of extubation. And maybe to even shed a little bit more light on that, depending on where you look and where you read, I've heard metrics as high, 15, 20% of the patients that you extubate should need to be reintubated if you're really appropriately aggressive about your extubation. So clearly it's not zero. And so, yeah, I think in this episode, we're going to touch on some of the literature that's out there. And then, as I mentioned before, we're going to hit some highlights with some cases a little later on.
Great. I think maybe we should hit some nomenclature first. So, depending on kind of what decade the critical care textbook you have is from, you may see different terms for this process. The term weaning is still used a lot, but I think it's largely being replaced by the term liberation from mechanical ventilation.
Right. So I think previously, this term weaning from mechanical ventilation was used, and it was even used, during the early years of my training. And I always thought, so what does that mean? Does that mean we're like dialing down the settings a little bit on every day? And I know in some cases you do that, depending on the type of patient, all that. But generally speaking, I think liberate is a much more appropriate term, because a lot of times we're not doing that. We're kind of like, okay, they're good to go. Let's test them and then move on.
Right, exactly. In most cases, we're not gradually withdrawing support. We're basically saying, okay, this person is ready on their own to liberate. So I think in so much as nomenclature matters, I think we should probably use the term liberate instead of weaning.
Yeah, I totally agree with you. And I think, there's also the idea of, liberating or liberation. It's got this positive energy. You can almost imagine like a group of protesters saying, liberty, give me liberty.
Right. Liberty, equality, fraternity.
Oh, good. Back to France. Butchering the French motto there, Nick. Great work.
I like liberation because it has this sense of urgency to it, right? It's like those protesters are chanting, what do we want? Liberty. When do we want it? In 24 to 48? No, they want it right now. Like, right. Liberate now. There's a bias towards action. That's why it's a good term.
All right, fine. So perhaps we'll start calling it liberté.
Liberté. All right. Another nomenclature point. I really don't like it when somebody says that a patient failed an SBT, right? And I don't like it for a couple of reasons. First of all, failure is summative, right? Like, I want to know how they failed. I want to know why did they fail, because hopefully those are things that we're going to fix. Just saying somebody failed is, it's kind of summative, and it's not very useful, right? Like, I want to know what changes I can make so that they will succeed.
That's a great point, Nick. And beyond just the connotation of failure, using the term "they failed" is like the exact wrong way to use patient first language. It's like the patient failed. So no, first of all, I would argue that no one failed. It's just perhaps this isn't the right time. We didn't
No,
approach it correctly,
we
whatever.
failed. It was
But
our
yeah,
job
well,
to extubate them.
exactly. Or if anyone failed, it was us,
Right.
as the clinician. So yeah,
Yeah.
it's kind of a funny paradigm.
I also don't like viewing reintubation as a failure, right?
Unpack that for me. What do you mean by that?
Yeah. Well, so you alluded to this before, but I mean, if you aren't reintubating people, it means you're not extubating enough. You kind of have to choose which side you want to err on. Do you want to err on the side of extubating a little too often or not often enough? And if you extubate too often, you're going to have to reintubate some number of people. To put this another way, like in a typical week in the ICU, you should be extubating many patients and reintubating a couple of them. If you have a week with 0 reintubations, you should ask yourself, did I extubate people aggressively enough, early enough, often
Right.
enough?
Right. And a couple of points too. I think, if you're working in an ICU, you should have the airway skills to be able to reintubate those patients if you need to. You should be competent enough and confident enough to, be able to do that if need be. And then, another side of this discussion is really, despite our best efforts, and we're going to talk about some of these tools, we just don't have this like perfect magic ball, or if you're a Lord of the Rings fan, a Palantir to sort of look into and be like, okay, it's time. They're going to extubate perfectly. No worries. Let's go. We cannot bat 1,000. Man, I know I'm mixing my my analogies here, but in the spirit of baseball season, we can't bat 1,000, nor should we bat 1,000 when it comes to these patients.
That's right. That's right. And, recognizing that our assessment tools are fallible, we sort of have to choose, like, which direction do we want to err on? And I think, personally, I like to err on the side of too much rather than too little, too early rather than too late. I think you hit on another point too, which is that, like, it's not a big deal to reintubate somebody. Like, if you're good at managing airways, this is a routine, safe procedure that you can do. Obviously, like somebody who's got a super tenuous airway, I'm probably not going to extubate them in the middle of the night while I'm busy with other stuff.
Right.
That might be one where we, do it when, everybody is there in house. But this is something we've talked about before, but this like culture of outcomes versus culture of safety, right? Like the culture of safety is like, oh God, reintubation's a failure. We never want that to happen. The culture of outcomes is like, hey, we extubate people 12 hours earlier on average in this unit, which prevents this many cases of delirium, this many VAPs. It gets people mobilized sooner. It keeps their nutrition high. Like, focusing on all the good outcomes instead of the occasional reintubation, I think is the right way to frame it.
Yeah, I don't really think there's a whole lot more I have to add. I think you're hitting the nail on the head. We have to be vigilant in our search for patients who are appropriate for extubation. Again, as best we're able to identify those folks, we have to make that a priority, because really prioritizing that is prioritizing, in my mind, humanistic medicine, which is minimizing delirium, minimizing harm, which is why we're in this business. And ventilator associated pneumonia that doesn't need to happen, that's a harm. 7 out of 7 days of the week.
Yeah.
So yeah, I totally agree with you, Nick. I really don't have anything else I would caveat that with. Maybe though, we could take this opportunity to unpack some of those risks and maybe additional risks as it relates to, let's say prolonged intubations, especially those that maybe don't have to be as prolonged.
Yeah, great point. So let's kind of enumerate what those risks are. So the big 3 that I think about are ventilator-associated pneumonia, or VAP, critical illness myopathy, and then delirium. Those are probably the 3 biggest harms of keeping people on a ventilator longer than you should.
Exactly. And I think, thus far, if you're a devoted fan of the show, you've already listened to Nick and I talk about these issues with some really great guests. So episode 4, we talked with Wes Ely about delirium. Episode 21, we talked with Paul Wishmeyer about ICU nutrition and myopathy. And then actually, part of our discussion with Paul and Aline Gregosian was also discussing, some of these elements of ICU care as well. And then of course, recently with Kaylee Dayton, we talked about ICU mobility and have plans to do additional episodes on that topic. So just so you guys know, we really do care about this stuff a lot. It's really important.
Yeah, and if you recently started listening to the show, highly recommend going back and listening to those episodes on delirium, nutrition, and mobility. Those are really foundational.
Absolutely.
You won't be disappointed. So let's double click on each of those risks a little bit more now that we've kind of laid out what they are. So first off, the ventilator associated pneumonia risk. So depending on kind of, why you're intubated and what your risk factors are, your risks may vary, but the literature generally says that your risk is about 1 to 3% per day risk of developing VAP. And that risk is probably highest early in your illness. So about 3% per day for the first 5 days, maybe 2% for the next week, and then 1% per day thereafter. But it's important to remember that the mortality associated with VAP is quite high, like 30 to 50%. And so even if, keeping somebody intubated 5 days instead of 4, quote, only increases their risk of VAP by 3%, that comes with a pretty significant mortality risk. And so, there is real danger from infection in keeping somebody intubated longer than they need to be.
Yeah, it's definitely not a trivial consideration. So totally agree with all of that. Moving on to, ICU acquired weakness, myopathy. So it's pretty well known that people lose about 2 to 3% of their muscle mass each day when they're in the ICU on the ventilator. A lot of times these are folks that are on sedative medications, neuromuscular blockade. They're laying on their backs. It's just like they're set up for failure. And furthermore, really within the first 10 days of a hospitalization in the ICU under these conditions, patients can lose over 20% of their muscle mass, which can lead to that critical illness polyneuromyopathy that we're so worried about. And to kind of unpack this a little bit further, so we know that the diaphragm atrophies especially fast. So up to 6% of muscle mass per day you can lose in the diaphragm when you're on a mechanical ventilator. It has huge implications related to your ability to come off that ventilator, to live a normal life, to be independent, all of that. And then, if you think about this in the context of delayed extubation, well, every day we delay extubation, you're increasing the significance of these factors. You're reducing the odds of liberating the patient from the ventilator, and of course, reducing their odds of having a functional, independent life going forward.
And I'll just add to this that even if you do a great job in your ICU of mobilizing people while they're intubated, I guarantee you nobody who's intubated is mobilizing as much as if they were extubated.
100%.
So I mean, there's a big difference. Also, not to dunk on the Huberman podcast too much, but it's not like 3% per day, which means that after 33 days, you're at 0. It's, it's a percent of total. But remember that if you lose 20% of your muscle mass, that's maybe the difference between being able to pick up a carton of milk and not, being able to, lift up your grandchild or not, or being able to get onto the toilet or not. That's not the pulmonary toilet, by the way. That's the conventional toilet.
Oh, thank goodness. No, and I mean, and I know we're gonna, Nick, you're gonna walk us through delirium here in just a minute, but I just want to remind our audience, especially those who have been in ICUs and perhaps those that haven't. This might be kind of surprising, but Nick, I mean, how many times have you taken care of a patient who is extubated and kind of on the road to recovery and realize, or they come to this kind of brutal realization that they can't really walk?
Yeah.
I mean,
that's right.
That's terrible. That's something that's been normalized, I think, for me in a way. And that's just flat out wrong. And then beyond that, we're sort of keeping folks intubated for longer than they need to be, adding fuel to that fire. And it's just so horribly perverse. I don't know, Nick, what are your thoughts on that?
Yeah, that's right. I mean, and I think that, again, this is culture of outcomes, right? I mean, if somebody walks into the hospital or they come into the hospital being able to walk and they leave the hospital not being able to walk, that's a tragedy. And that's something that we often don't even see it unless we go looking for that. And, it's something we should do our best to collect that data so that we know how often it's happening. And we should do our best to make that a rare event.
Absolutely.
That shouldn't be normalized as part of critical illness.
I love it.
So I think that the third of that sort of trifecta, the 3 horsemen of the ICU, bad outcomes, is delirium. We had a whole podcast on this. I would encourage listeners to go back and take a listen. One study by Wes from 2001 published in JAMA basically found that the odds of developing delirium increased by about 20% per day that you remain on mechanical ventilation. So, some studies, another way to interpret this, maybe it's 10 to 15% per day, but, that's a very significant risk of delirium. And as we know from Wes's 2004 paper, the people who experience delirium are 3 times more likely to die in the next 6 months. They're more likely to stay in the hospital for longer. They're more likely to have lower functional status after discharge. So anything we can do to reduce the delirium risk, we should be doing. And a big part of that is getting people off the ventilator.
So, Nick, I have to imagine we've made a pretty good case as to why this is so relevant, so important to our listeners. Just to summarize, because we've talked about a lot of different numbers and a lot of different concepts here, consider 1 to 3% per day risk of VAP or ventilator-associated pneumonia in the context of being intubated, mechanically ventilated, which we know leads to an increased risk for organ failure and, of course, death. You've got a 2 to 3% loss of muscle mass per day, increasing your risks of, long-term debility, morbidity, potentially mortality, loss of function. And then finally, that 10 to 15% increase in your risk for delirium each day, which we also know is independently associated with death and loss of function.
Yeah, some scary numbers. Now,
Right.
I want to sort of caveat this and say we're not some crazy COVID doesn't kill people, the ventilators kill people wackadoodles, right?
Well, speak for yourself, Nick.
Yeah, those
Just kidding.
people are all over my timeline on Twitter or X these days. Obviously, if somebody needs mechanical ventilation, it's absolutely life-saving, right? But I think we need to be really mindful that ventilators come with risks and that those risks, depend on the duration of the exposure. So anything we can do to shorten that exposure reduces the risks. It's not saying we shouldn't be using ventilators. It's saying we should be using them parsimoniously, as short as possible.
Yeah, and I'm hoping that that's really well put, Nick. And anyone that has concerns or is a little bit skeptical about ventilator practices and perhaps the speed with which you put someone on a ventilator, hopefully they'll catch wind of this podcast and realize that there's a ton of thought that goes into the process of intubation and extubation when you're doing it right, and we are really just trying to model what right looks like here.
Yeah, well said. I also think, just as a minor side note, I think we should measure the duration of mechanical ventilation in hours, not days.
I
Because
love
I
it.
think it probably does matter. I think if we're measuring, with a finer ruler, we're gonna do a better job. It pushes us to extubate people in the afternoon or overnight, as opposed to this sort of, we only extubate once a day in the morning after SBT mentality that you see in many ICUs. So I mean, anything we can do to shorten this is a good thing.
I love it. Awesome. So Nick, now that we've talked about sort of the why behind the what, perhaps we can, get into some of the nuts and bolts as it relates to extubation.
All right. So now that we've emphasized why extubation is so important, now let's talk about how we can assess our patient's readiness to liberate from mechanical ventilation.
Awesome. So this is when we use something that is called an SBT, or a spontaneous breathing trial. And so this is when we change the ventilator settings. And as a side note, I know we're talking about ventilators and we haven't even done our, ventilator magnum opus. It's coming. And we'll get to all of this soon. But I digress. So what we'll do is we'll change the ventilator settings to provide a lower level of support and allow the patient to do more of the actual work of breathing. And I want to make a couple points here. We do this when it's appropriate for the patient. When a patient is in the throes of their pulmonary disease or their medical illness, that is not really the time to test their ability to breathe on their own. The purpose of a ventilator is to save lives, provide lung rest, and so, during the throes of illness, we want to support that patient to the extent that they need to be supported. Once they have gotten better and we feel that they may be a good candidate for removal of that endotracheal tube, that's when we're going to do this SBT, where we're going to reduce sort of the support that they're given in a very intentional way. The other point I want to make is an SBT and an SAT, or a spontaneous awakening trial, also referred to as like a sedation holiday, sedation vacation. I like SAT, those are not the same. They are not synonymous. In my practice, in my ICU, unless there is a clear contraindication, whatever that may be, every single morning at least, or as often as possible, your patient should be awake and should be getting those spontaneous awakening trials. And really what that looks like is we kind of cut the patient's sedation and do a good neuro assessment and really get a feel for what they actually need from an analgo sedation standpoint. But this can be done. It has nothing to do with kind of their ability to necessarily breathe on their own. That being said, when you do an SBT, you should also be mindful that that person is on an SAT, because if they are heavily sedated and heavily, let's say they have like neuromuscular blockade on board, probably not the time to set the ventilator mode to spontaneous.
Right, right. It's unfair to expect somebody to breathe on their own if they're not awake.
Right.
The two go together. I've always kind of wondered, you mentioned like airway holiday. Is that like the European version?
Yeah.
Is it like a sedation siesta in Spain?
I like that, sedation siesta. The other thing too that we'll talk about is this idea of a wake up and breathe trial. I think that's very, very like kind of in your face, but also very descriptive. And that's all different sort of like ways of painting the same sort of picture. And then the last thing I'll mention too is just a lot of times people ask how long this should last. Typically, a spontaneous breathing trial is about 30 minutes in length. You can extend that. I think as the longest you really might want to do is like an hour and a half to maybe 2 hours, but that's a really long time to let someone sit on an SBT if you're not going to extubate them.
I think the point is that the information that it's going to give you sooner than that.
For sure.
So, it's one thing to be like, hey, this person's not doing so great. Let's try to adjust something and see if they can do great. That's a reason to do longer ones, but it's been studied and longer SBTs don't give you any more information. And many people who would do just fine extubated appear to tire out if you do a really lengthy trial.
Yep, that's right.
We should probably talk about who qualifies for an SBT. And so, obviously, people who are in the throes of critical illness, who need a high level of ventilator support, these are not the patients who we're going to be taking the ventilator away. So typically we'll use thresholds like an FiO2 less than 50%, a PEEP less than or equal to 8. I think it's also important that they're, able to manage secretions, pulmonary toilet, if you will. And they need to be awake enough to follow commands. But
I won't, by the way, but continue.
Yeah, I think it's important to remember that you can perform an SBT even in somebody who doesn't quote qualify. Just because they're on too much support to extubate doesn't mean that it won't give you valuable information about their respiratory mechanics. It just means that, okay, this was sort of a bonus test we did as opposed to like, an indication to take the tube out right away. So maybe we should talk about kind of what the nuts and bolts settings are when you do this. Like what is the respiratory therapist going to change on the ventilator when you actually do a spontaneous breathing trial?
Yeah, so there's a couple different options, and a lot of times they're going to be dictated by your institution. So you can use kind of have a low level of pressure support. That's one way to do it. You can use something called ATC, or automatic tube compensation. You can do sort of like a quote unquote CPAP trial, where basically the patient is still, intubated, mechanically ventilated, but you just have them on a continuous amount of pressure that is being delivered through the device,
So no pressure support. Yep.
Exactly. No pressure support. And then finally a T-piece trial.
And I like the way you put those kind of in order, because it's kind of like low level pressure support and ATC are kind of like more support, CPAP and T-piece are kind of harder. So let's kind of go through those one by one and talk about the nuts and bolts. So tell us about low level pressure support.
Yeah, so with low level pressure support or PSV, pressure support ventilation, the ventilator is really giving minimal inspiratory pressure support, and the patient is expected to breathe spontaneously. So typically, what you do is you have the patient getting an expiratory pressure or a PEEP of 5, let's say, and then you're giving them typically 5 to 8 or so of pressure support above that PEEP. So we'll say like 5 above 5, or 5 over 5 is another way to put that.
And just to explain kind of the physiology of this, the idea behind providing this low level pressure support is that it's more work to breathe through an endotracheal tube because of resistance, right? An endotracheal tube, by definition, has to fit through your vocal cord, so it has to be smaller. Right. And as the diameter drops, the resistance increases. And so, it's harder to do this. And so the idea of low level pressure support is basically to kind of make it kind of fair, provide a low level pressure support. We can compensate for that increase in resistance kind of approximately.
Absolutely. So kind of similar to that, next rung on the ladder would be something called automatic tube compensation, or ATC. And so it's similar to what we just discussed, but basically it's a mode, or it's a setting typically within whatever mode you're actually using, that compensates for the resistance of the endotracheal tube, mimicking natural breathing conditions. So basically, so long as the ventilator is programmed with the size of the endotracheal tube, the appropriate amount of compensation can be applied based on that tube.
This is kind of the smarter version of low level pressure support, right? Where it's giving a precise amount of pressure to exactly compensate for the added resistance. So it's kind of like, PSV that went to college.
Yeah, I like that idea. I like calling it sort of PSV that went to college. Okay, so next on the list would be a CPAP trial, the so-called CPAP trial, which is basically you place the patient on kind of a continuous pressure of 5 centimeters of water without any inspiratory support.
And this is really just PEEP, right? I mean,
Right.
CPAP and PEEP are the same thing. It's just whether you're intubated or not, and this would often be called like 0/5 as opposed to 5/5, that low level pressure support you mentioned.
Right. Right. And I mean, it's kind of, as you can imagine, it's kind of harder to pass this than the other. And we'll talk about what passing means. We haven't even really defined that, but we'll get to that. But it's harder to have a successful SBT by way of CPAP trial than the other options we've discussed thus far. And that can be beneficial if you're trying to sort of make the threshold higher, which you may want to do in certain cases that we'll discuss later.
Yeah, exactly. It's, because now you have all this additional resistive work of the tube that it's not helping you with. So it's a harder test.
Yeah. And so finally, there's this idea of a T-piece trial. And in a T-piece trial, the ventilator is actually removed. And all we do is we have the patient breathe through what's called a T-piece, which basically tees in supplemental oxygen so that the patient has that oxygen support.
So endotracheal tube still in, ventilator
Yes.
off. Yeah.
Yes, exactly right. And so they basically get oxygen through, they've got their tube there, and then they have they exhale through the other half of that, the other portion of that tube. It looks like a T. And as we sort of mentioned or alluded to, at least there's no positive pressure support here in a T-piece trial.
Right. And in fact, this is actually negative pressure ventilation. They're breathing just like they would without a endotracheal tube. So this has the it's harder because you have to overcome the resistance, and whatever benefits they were getting from PEEP are now gone too. So this is like the hardest of all possible ways to do an SBT.
Yes, it's the final boss of SBTs.
Yeah.
It's kind of some people will call this approach zero PEEP or ZEEP, a ZEEP trial, and it can be helpful again in certain cases. In particular, if you're worried that PEEP is actually preventing something like flash pulmonary edema from occurring, you take away that PEEP, and it kind of answers the question, whether or not that's truly the case.
I sort of think of this as kind of the old school way of doing it. I think
Right.
nowadays, most places probably use ATC or low level pressure support. Those are probably the most standard ways. I think occasionally this is something you could reach for if you want sort of a harder test. Like you want to see how somebody's going to do without that PEEP, for example. But, I would say this is a pretty unusual way of doing it nowadays in 2025.
Yep, I agree.
So great overview of the different vent settings modes you can use for an SBT. I think we should also, just acknowledge that, there's debate about, which of these your institution likes, and why some places still use some use others. Maybe instead of getting into that whole, rigmarole, we should just talk about kind of the other things that go with an SBT, because SBT is a lot more than just, changing vent modes, right? Like, so what else is there?
Yeah, I think that's a great point. So obviously, you're going to want to turn off the sedation and explain to the patient what's happening as they're waking up. Coach them through the process. Tell them, "Hey, we're waking you up. We want to see if you're going to be able to breathe on your own. In order to do that, we're going to change the ventilator settings to sort of mimic how you might breathe on your own. So just relax. Try to take some slow, deep breaths, and then once you're sort of settled down, just breathe normally. And just I think approaching it with a cool, calm, and collected affect can be very helpful, as this can be a stressful time for your patient.
Absolutely. Yeah. And I think this is sometimes a great opportunity to have family present. Sometimes it's kind of a nice to have a distraction, familiar people, and I love the way you describe it as coaching, because that really is a key part of it. Like you want somebody to succeed at an SBT. In many cases, the difference between passing and failing is, the right sort of emotional support that goes with it, good instructions, calm presence in the room. So doing all of those things is key.
That's right. Absolutely. And as far as that sedation goes, we talk about turning it off. There are some caveats to that. So for many cases, turning everything off makes sense. But other times, low dose dexmedetomidine or low dose ketamine can actually be helpful in making that transition. One of the things that I do not infrequently is I'll have someone on low dose dexmedetomidine and actually extubate them on that, transition them, let's say, to a non-invasive if I think they would benefit from that. And then once the dust is really settled, then we can start to sort of, wean the non-invasive and wean the dexmedetomidine to sort of just make for a smoother transition, again, in the appropriate patient.
Yeah, exactly. I think, ideally you want everything off, but in
Right.
some people you want, a little bit still on. It's kind of performance enhancing for an SBT to be on some degree of mild sedation.
I like that. So let's say that we are, initiating this. We've got them on PSV, or that pressure support ventilation, at 5/5. What should we be looking for? What are we monitoring, Nick?
So I always tell people that, what you're looking at is really four things. Okay. And, the first thing you look at is the patient. If the patient looks bad, we failed the SBT. The next thing you look at are the vital signs. If those are bad, you failed the SBT. We failed the SBT. The third thing you look at is the ventilator. If that's bad, fail. And then finally, you look at a blood gas, and you don't even necessarily need to do that in everybody.
Right.
So let's go through those kind of one at a time. So what do I mean when I say look at the patient? Well, you want to look at kind of, first of all, what is their work of breathing? If they're using accessory muscles, if you see nasal flaring, if they're diaphoretic from the effort, those are bad signs. Those are signs that somebody is not going to do great without the ventilator. Also, if they look panicked, that may not be a sign that they're going to have trouble breathing on their own. It may just be that the test is really uncomfortable for them. So sometimes that's a situation where what we really need to do is kind of change course, use a little more sedation, coach them, maybe try again a little bit later. But, if they look bad, it is bad. Next up, assuming the patient looks okay, turn our attention to the monitor. So look at the pulse ox. If they're desaturating, that's bad. Look at the heart rate. If they're tachycardic or bradycardic, or they're having a significant number of arrhythmias, that's bad. Then look at the blood pressure. Sometimes people who are in distress will be hypertensive. Sometimes they'll be hypotensive. And then as kind of an added bonus, in anyone where you have SVO2 or SCVO2, I always look to see how that compares to before the trial. There's a couple studies that show that a drop in SVO2 greater than 4% is strongly predictive of extubation failure. Essentially, what you're seeing is that they're having to extract a lot more oxygen in order to do the work of breathing on their own, which often suggests that they won't be able to maintain this for a long time. So look at the ventilator, look at these numbers, see if anything looks crazy bad. If so, that's a fail.
And I like that. I like that SVO2 trick too, because it's sort of like is an objective check on what you're seeing with your eyeballs. And it's like, okay, if that person's, if that person's working harder to breathe, is it more that you're, seeing their anxiety kind of come through, or are they truly working harder to breathe? And then you get that SVO2, that SCVO2, and you're like, oh yeah, they've, before they were at whatever, and now they've dropped 5, 6, 7%. Okay, this seems real.
Yeah, no, it's a great sort of free data point you get if you have the SWAN in, and so always look at that if you have it. Next, I like to look at the ventilator, and so there's a couple of different parameters here to look at. There's the tidal volume. Is it too high? Pull at a liter, or is it too low? They're pulling just 100 mils per breath. Those are both bad. And then look at the respiratory rate. Is that too high or too low? Are they breathing 40 times a minute or just 5? Those are clearly bad.
Yeah, for sure. And then, we can do to take the sort of product or the composite of those values too. So you can look at the tidal volume and the respiratory rate in conjunction. And that's what we colloquially refer to as the minute ventilation. So the tidal volume times the respiratory rate. And you can sort of think of this as almost like the, cardiac output for the lungs. So, remember cardiac output, heart rate times stroke volume. This is tidal volume times respiratory rate.
And coincidentally, a normal minute ventilation is going to be about the same as a normal cardiac output. So for example, like if your tidal volume is 500 mils and you're breathing 12 times a minute, that works out to be a 6 liter per minute minute ventilation, which is about the same as your cardiac output. Kind of when I look at minute ventilation, I'm kind of asking myself two things. Is it adequate and is it sustainable? So is it adequate as in it's going to be enough ventilation to excrete carbon dioxide? Generally, people are going to need more than 3 liters per minute or 4 liters per minute in order to do that. And as for sustainability, I want to make sure it's not crazy high. If somebody is blowing, 15 liters per minute of minute ventilation, that's probably not something they're going to be able to maintain for hours and hours, days and days.
And with that said, of course, there are exceptions, right?
Absolutely. So, I mean, there may be people who always have low tidal volumes and high respiratory rate. They may reach the same amount of ventilation in a different way. So, for example, somebody who's got severe kyphoscoliosis, they might just be pulling fairly small volumes and breathing a little faster. And in this case, you really ought to ask yourself, are they back to baseline? Is this how they normally breathe when they're not on a ventilator? There's also people who may need more minute ventilation. So if somebody's having a fever, if somebody's got resolving DKA, they may need more than 5 or 6 liters per minute to be an adequate ventilation. And so you should put that in context. Sometimes somebody is having a fever and they're still passing, but their minute ventilation is a little high. That's probably somebody I would extubate anyway. You can give them some Tylenol afterwards. I wouldn't keep somebody intubated if it's something that I think, is improving. Right. That said, if somebody has got a crazy high ventilation, I'm always worried, like, are they really going to be able to keep this up? So you got to contextualize.
So, Nick, we talked about one way you can kind of combine the tidal volume and the respiratory rate. Is there another sort of metric we can use?
Oh, your favorite, in fact.
Yes.
So, instead of multiplying them, you can divide them.
Right.
So there's the rapid shallow breathing index, which is the respiratory rate divided by the tidal volume in liters. So if we go back to that normal example, you have a respiratory rate of 12 divided by 500 ml or 0.5 liters. So 12 divided by 0.5 is 24. And in the original study of this, they found that an RSBI greater than 100 or 105 was highly suggestive of respiratory failure. So there's a big margin between how you and I are breathing right now and what an RSBI that would suggest failure is. Now, I know you have some thoughts about RSBI.
Yes, I do have quite a few thoughts about the RSBI. So the RSBI, that kind of is derived from a study, I think it was like in 1991, if memory serves, it was in the New England Journal of Medicine. So it's almost older than me, almost. And it was two authors, Yang and Tobin. Yang kind of gets the shaft, for lack of a better term, because we talk about the Tobin index. I think Tobin was the attending, was his boss essentially. But we call it the RSBI or the Tobin index. We rarely call it the Yang Tobin index. So that just rubs me the wrong way right out the gate. And so, when I talk to trainees, I talk to folks about this, it's like, okay, we have this RSBI. It's this like really great tool, right? And so surely if this is sort of like the standard that we hold all our patients to, there have to have been like jillions of patients that were studied in this study, right? And
Nope.
the reality is no. Let me back up and say essentially the first study or the original study was using a spirometer and a T-piece trial to essentially do the spontaneous breathing trial, which is certainly not how we do them typically nowadays.
And as we said, that's much harder than the way we typically do them now.
Right. Much harder than we do them now. And we know, in fact, that depending on how you approach the SBT, you're going to get different RSBIs. And as I had alluded to before, there were 100 patients in this study, 100 patients.
And it's actually worse than that.
It is
there
worse
was like
than that.
A derivation cohort of 36 and a validation cohort of 64. So it was really developed on 36 people at one institution back in 1991. So back when like CD players and Discman were really in vogue was when this study came out.
Yeah, if that. I mean, like people were probably like
tapes.
Tapes. People were still listening to tapes. Yeah, for sure.
So it's not quite the 8-track era, but it's old school.
Oh yeah, it's crazy. And Nick, I think you liken this to a couple other situations in critical care where we make these sweeping generalizations based on minimal data, right?
Yeah, no, I think you're right. I mean, and if you look at the evidence for it, not only is this original study kind of flimsy, right? One trial, small trial, single center a long time ago. But when you look at like pooled meta-analyses, the performance ain't great.
No.
I found one meta-analysis where they found that the RSBI had a moderate sensitivity of 83% and a poor specificity of 58%. So, it kind of suggests that patients who are truly ready for extubation might be missed if we use RSBI alone, and a significant number of people with a passing RSBI, an acceptable RSBI, will still fail.
Right. Absolutely. And so like, this 105 number that was derived from this like quote unquote 100 but really 36 patients, is it the right number? Should it be 105 for everyone? Should it be 85 for folks with COPD? Should it be 90 for folks with asthma? Should it be 92 for folks with bronchiectasis? I don't know.
Yeah.
And then remember, again, we used T-pieces, or they used a T-piece for the derivation of this value. And it was also, a time when, again, like prevalence of obesity, neuromuscular disease, prevalence of COPD. I mean, these are all things that have changed in the last 30 years or so. And so I think that's part of why I rage against folks hanging their hat on the RSBI as this kind of be all and end all.
So bottom line is for me, man. Should we use it or not? Should we divide? Should we do this quotient, or should we just skip it?
Okay, so I'll try to end my rant here and say, I think that it's useful as a tool in your toolbox. If a person has pre-existing anxiety, their RSBI is going to tend towards being higher. There's data for women tending towards higher RSBIs. We've talked about a whole lot of confounding elements here, but I would say if at the end of the day, to be fair, the RSBI is looking at respiratory rate and tidal volume. We just talked about how a patient that's likely ready for extubation is probably not breathing 30 times a minute, tiny tidal volumes. Do I need to calculate their RSBI to see that? Probably not. I can kind of eyeball them, and if they look like a fish out of water,
we're using those two numbers individually and multiplying them,
right.
Taking those two numbers and dividing them. It's like, okay, if that's how you think, then great.
Yeah.
But
so yeah, I'm going to eyeball them. I'll see, I can kind of make some determinations on my own. The ventilator, when you're on a spontaneous mode, often is going to spit out the Tobin index or the RSBI anyway. So you'll have that there to review. And I think it's a fine thing to use as one of many tools when you're making this assessment.
Yeah, I think, as with many things in critical care medicine, it's all about gestalt, right? Like put the whole picture together.
Right.
And so, like we said, we're looking at the patient, we're looking at the monitor, then we're looking at the ventilator, then we're looking at the blood gas. This is just one little number on the ventilator. It's one tiny part of the assessment. I wouldn't hang my hat on this to make a decision. Sure, if it's wildly different than what I'm expecting, maybe I'll attach some importance to it. But I think it sort of, gets this like disproportionate amount of attention when it's really just this little tiny part of your assessment.
Right. I mean, I think what grinds my gears is like when you have a discussion about extubation and someone just kind of from the, from left field is like, oh, but what was the RSBI? And it's like, well, I don't care. It doesn't matter. Like here it is, but also like I just gave you a dozen other reasons why we either should or should not proceed. Okay. So I'm exhausted. My blood pressure's up. My RSBI is elevated. Maybe we could close this portion of our discussion out.
We'll start some dexmedetomidine for you. And then, I will continue.
Yes.
So the blood gas. So first off, do we need an arterial blood gas?
Yes.
Answer, no. Really what we're looking at here is we're like, are they adequately ventilating? Are they hypercapnic? And so I really don't need to poke them to get arterial blood in order to answer that question. Obviously, if they have an art line, sure, we'll draw blood from it. I'll use it. But the key question that I'm asking here is really about CO2. So a VBG is fine. Also, if I have a reliable pulse oximeter, I can assess their oxygenation that way.
Yes. And so totally agree with that. And so is this like a routine part of your practice or do you, when do you check it? When do you not?
I think if you have an art line, I'm going to check it because it's really easy. If you have a central line that draws back, I'm going to check it because it's easy. It's a point of care test. It takes, literally 2 minutes to get the result. Why not? But in somebody, maybe I don't have great access, it would require like poking them. I'm going to kind of think, do they really need this? And in many cases you don't. So I ask myself, like, why were they intubated? If it was for acidosis or respiratory failure, then yeah, I probably do want to know what their pH and CO2 are. But if they were intubated for something else, if they were intubated for like airway protection and they have no reason to think that they'd have a significant acidosis or CO2 retention, then maybe not. One study I found that in 93% of cases, ABG did not change extubation decision. You could look at that two ways. In 93% of cases, it didn't change your mind. Well, in 7% of cases, it did. And so, I mean, if the information's there, I'm going to look at it. If the information is not there and I am not worried about it, my pretest likelihood is low, I might skip it. It is worth noting that a low bicarb is associated with a much higher risk of reintubation. So that always kind of, whenever I see a bicarb like less than 18, that always kind of makes me nervous. And that's a situation where I really like to see what their pH is.
Yeah, and I think too, with that, I didn't get a chance to review that study that you cited, Nick, but you also wonder, like, at what point in the patient's courses were they being considered for extubation? So in theory, if you were kind of aggressive about extubation, and kind of working towards earlier extubations, maybe that ABG is more useful. But if it's clear as day to everyone in the room that this person is ready to be extubated, then yeah, the ABG is unlikely to move the needle.
Yeah, and actually, one situation where I find a blood gas can be very useful is you put somebody on an SBT and they're kind of doing so-so, and you get the blood gas and it's like not great. It's like a pH of like 7.3. Their CO2 is maybe 50, and you're like, let's just kind of let them wake up some more and check again in another 20 minutes. And then you get another VBG, another ABG, and their pH is now normal. Their CO2 is now normal. They're more awake. Sometimes it's just another data point that says like they need a little more time to sort of settle in. Let's check again.
For sure. Again, not a be all and end all by any means, but hey, take a look at that lactate too. If your blood gas spits out a lactate, and the person's been on a SBT for an hour and you have a pre-lactate, now their lactate's up and nothing else has changed, that might also be indicative of this person's working harder.
Absolutely. Yep. Or if you're a surgeon and you think in terms of base excess, if that's going up.
Sure. Absolutely.
Or
Totally
rather, if you're a surgeon and you think in terms of base deficit and that's increasing, that's kind of a red flag too. So, if you're going to get the data, you might as well look at all of the numbers on the printout.
So that was a great discussion, I think. And Nick, thanks for tackling that question about, blood gases. So let's say we look at the patient, the monitor, the gas, the ventilator, everything looks great. Do we just sort of like pull the tube out now, or what do we got to do next?
Yeah, so there's one more really, really important step, which is checking for cuff leak. And I know we're going to talk about that in a case, but just at a very high level, this is just where you're making sure that there is that you can get air around the tube, that there isn't swelling against the tube. And so this is kind of that final step, after somebody has passed and you've decided you're going to extubate, this is the last thing you check.
Absolutely. Yeah, I think, and it's a little bit of a controversial topic, which we'll discuss, what do you actually make of the cuff leak? We're going to get into that when we get into our cases. I think there is a discussion to be had about, what do you extubate the patient to? And, I think we're going to probably tackle that in our cases.
Yeah. I mean, you could extubate somebody to air. You take the tube out and they're breathing ambient air. That's great. In many cases, we'll extubate people to a standard nasal cannula, give them a couple liters of supplemental oxygen. Not everybody needs that, but that's often what we do as a standard. Some patients clearly benefit from going to more support though. In some cases that means extubating to high flow nasal cannula where you can deliver a significant FiO2 and a reasonable amount of flow. And in some cases, they need even more support. So you're going to extubate to non-invasive positive pressure ventilation. There's kind of a place for each of those. I think that, in general, it is better to extubate somebody to more support that they need than not enough support. Because in many studies, we find that if somebody is extubated and an hour later they're not doing well, instituting non-invasive ventilation then is probably not a great move. It's better to be proactive about, extubating people to more support and then weaning that support subsequently rather than going the other way. Because usually what happens is somebody gets extubated, they're not doing great, they're failing, they get put on high flow, they get put on non-invasive, and guess what? They're still failing.
Absolutely. So yeah, we're going to get into all that a little bit more here in our cases. Last thing I kind of wanted to do is just make sure that we clearly outline sort of our barriers to extubation. And so I think, we obviously mental status is something to consider. So you want to make sure that that patient is able to follow directions, they're able to engage you, they're sort of like at or close to their baseline, so that you can make sure they're going to be able to kind of successfully make it through this period. We talked about the respiratory parameters already. I'm not going to belabor that further. We talked about cuff leak. We're going to get to that again. And then there's also these ideas of sort of secretions and ability to manage secretions. So of course, if someone's got a lot of oropharyngeal secretions and they're not able to keep them from going back into their trachea, that's a problem. And of course, hemodynamic stability. So this is why we talk about making sure that the patient is sort of through the apex of their disease when we're going to extubate them. If someone's like in the midst of septic shock and potentially getting worse from a hemodynamic standpoint, probably not the time to consider removing the endotracheal tube.
And, actually, we talked about this in the physiologically difficult airway episode. The transition from negative pressure to positive pressure has significant hemodynamic effects. And that's something you need to think about as well here, that going from positive pressure to negative pressure can have significant hemodynamic effects. So somebody who's got like heart failure with pulmonary edema, they may not tolerate this really well. So you need to be cautious. Anyway, lots of ways that you can fail. Lots of things that can go wrong. Let's talk about some specific examples of them. Let's do some cases. Before we move on to our exciting cases, we are proud to announce a new sponsor. This episode of Critical Care Time is sponsored by the Difficult Airway course.
The Difficult Airway course, Critical Care, is the premier airway management course designed specifically for critical care physicians and APPs by practicing airway experts who understand the unique challenges of managing airways in an ICU setting.
This includes deep dives into topics including anatomically, physiologically difficult airways, rapid sequence intubation, awake intubation, surgical airways, airway ultrasound, high-risk extubations, and much more.
Now, you won't just be watching folks manage airways. This course provides hands-on, evidence-based immersive training with code airway stations designed to prepare you for a wide range of situations you're likely to encounter.
Plus, the Difficult Airway course is taught by world-renowned experts who share the tips and tricks they've picked up over many years of experience on the front lines.
Fortunately, the Difficult Airway course is offered twice in 2025, once from May 2nd to 4th in Boston, and again from November 14th to 16th in San Diego.
Tuition includes a copy of the new textbook, Manual of Airway Management in Critical Care. And because you are a Critical Care Time listener, you get a special discount. Use discount code CCTIME25, that's CCTIME25, at checkout and save $250. Damn, that's great.
That's awesome. Maybe you can spend some of that at our store. Hey, anyway, make sure that you check out the website, www.theairwaysite.com/critical care to learn more.
Gain the confidence and competence to manage the most complex airway cases, even when the pressure is on. Because when it comes to airway management, there is no such thing as being overprepared.
Ain't that the truth? And now back to our cases.
All right, so case number one. So, Cyrus, I've got a 55-year-old man who had a routine spine surgery yesterday. It was a long case. He was prone for a long time, in the OR all day, oozy and bleedy, got a bunch of units of blood transfusion. So decided to keep him intubated overnight. This morning on rounds, he passes his SBT. He looks good. You give RT the nod to extubate. They grab you 5 minutes later and they say, hey, he's got no cuff leak. So Cyrus, how do you what does this mean? How do you approach this guy?
Perfect. So just to kind of foot stop what you said earlier, what is the cuff leak? Well, that's basically the ability of air to escape the tube or around the tube when the cuff is deflated or the balloon is deflated. And why that's relevant is it allows us to assess for any sort of significant glottic edema. And so you can imagine if you've got an endotracheal tube in place, that's kind of stenting open the trachea in the setting of edema that is sort of surrounding the endotracheal tube. Once that quote unquote stent is removed, you then set the stage for that edema to potentially overwhelm the trachea, causing stridor respirations and respiratory collapse.
Right. And so in this case, this is probably because this patient was prone for a long time. They have dependent edema of their face and their vocal cords and their other glottic structures. They got a lot of crystalloids, they got a lot of blood products. And so, this is not unexpected to see it in this circumstance. But maybe we should back up and say, like, what did RT do? Like, how did they measure this?
Yeah, that's a good point. So typically what you're going to do is you're going to deflate the balloon, so on the endotracheal tube, and then you're going to look at the ventilator scalars and look at the volume that is exhaled and the volume that's inhaled, those measurements. Because remember, your ventilator is going to have both of those values. Normally they should be pretty much the same. When the cuff is down, you're going to expect that the exhaled volume is actually going to be lower than the inhaled volume. Why? Because there's air that's escaping out of the circuit that the ventilator is unable to capture.
And you may even see an alarm. It may
Yes,
say like low VT sub E, right? The
exactly.
exhaled volumes are lower than expected. That's actually good news.
Yes, that's right. And then you could also see kind of on the scalars, the volume scalars, you can see there's some discontinuity at the end of the breath. As kind of like a little visual representation. So that's helpful. I haven't really done this myself, but you could also just switch the patient out to a BVM. You could bag them and listen for air escaping. But typically, if they're on the vent and you drop the cuff, that's pretty good for me to see if there is a cuff leak or not.
Absolutely. And I think using the ventilator is probably a more sensitive test than
You're right.
like using your ear and
Right.
being like, that sounds like 100 mLs.
Yeah.
That's kind of the old school way of doing it, I think. All right. And so like what if like in this patient, they were prone for a long time, they have some edema presumably, and they have no cuff leak.
In cases like this, we identify that there is no cuff leak. We may actually just go ahead and give them corticosteroids prophylactically because they're at high risk for having compromise. And how we might do that, so dexamethasone, 5 to 10 milligrams IV every 6 hours. You might start that about 4 hours prior to extubation, and you'll do that for 12, 24 hours, leading up to extubation.
And I think it's important that, this is kind of like, you do the SPT in the morning. Oh, they don't really have a cuff leak. Let's give them some let's give them some dexamethasone and let's see where we are in like 6 hours, right? Like it doesn't mean we're not extubating them today. It just means we're going to extubate them a little bit later today, perhaps. I should also say this is based on a placebo-controlled double-blind trial that randomized a whopping 86 people with no cuff leak to dexamethasone or placebo, and they found that the rates of post-extubation stridor were reduced with dexamethasone, like 10% versus like 27%, but there was no difference in the reintubation rate, which was very low in both groups. So I think there is benefit to steroids here, but it's probably not as huge a benefit as we might think.
Absolutely. And I think, to your point, Nick, or the way you sort of crafted the case, this is someone who's gotten transfusions, they were prone for a while, probably got some, crystalloid and colloid. So they're kind of, they're at reasonably high risk for having this fate befall them. And so other things to consider, maybe some diuresis, this idea of sort of like liberating or reclaiming the volume that you gave them when they needed it.
Right. We lent it to them. Now we want it back.
Exactly right. And then also just basic stuff like keeping the head of the bed elevated might help too.
Yeah, exactly. I think this is a situation where, hopefully, when they came to the ICU, you didn't put them on maintenance fluids. You were parsimonious about more fluid. Maybe you can be proactive about diuresis, and set yourself up for success. But if you wind up in the situation where somebody has no cuff leak, think about steroids, think about diuresis if it was a volume issue. And then, yeah, just try again later. It doesn't mean you failed for the day. It just means, see where you are in 6 or 12 hours.
Great point. And so, on the topic of cuff leaks, just to close this out, as I sort of said before, the absence of a cuff leak does not mean you can't extubate that patient. And, context, as we mentioned many, many times on this show, context is important. This idea of an absent cuff leak is actually addressed in the joint ATS ACCP guideline from 2017. And essentially, the sort of algorithm they lay out is you identify a patient who's ready for extubation, consider do they have risk factors for laryngeal edema, things like a traumatic intubation where they intubated for greater than 6 days, did they have a large ET tube, things of that nature. If they don't actually meet those criteria, the recommendation is to just not even check for a cuff leak and extubate the patient. Now, there may be other caveats to that, like, Nick gave us a case where there was, fluids that were given, patient was prone, et cetera, et cetera. not a bad idea, I think, to check a cuff leak. Then if you look at this guideline, okay, so you check and they fail, they don't have a cuff leak. Really, the next thing you should do is carefully repeat the test. And if they still don't have that cuff leak, then as Nick described, you're going to give them steroids. We talk about giving dexamethasone. You could potentially give methylprednisolone. And then once that's done, you're going to extubate that patient after 4 to 6 hours, even if the cuff leak is still absent. So even if they still might have some of that edema. And so really this pathway, like all roads lead to extubation, to be completely honest, because that is such an important priority in the ICU. Now, the last thing I'll say is, according to the guideline, if you have this patient who's kind of had this persistent lack of a cuff leak, you extubate them. They're probably not folks who you're going to extubate and then send to like the progressive care unit or whatever, within an hour. You're going to want to have your supplies ready to reintubate that patient, potentially give them more steroids, things like nebulized epi, maybe even Heliox, which can be used as a temporizing measure.
I always love when they say Heliox is a temporizing measure, because at least in my hospital, it takes the RTs like 6 hours to find the one tank of it in the sub basement.
Right.
So like by the time the Helioxes arrived, like it's all over.
Yeah. And I should say too, I'm a big fan of Josh Farkas's work. He does a good job of kind of outlining this and discussing this in his Pulm Crit website. So y'all should check that out too, if you're interested in more.
And we'll have this this figure that you're alluding to, this great figure from the joint ATS ACCP guidelines on our show notes as well, if people want to take a look at it. I guess one other minor point that I would add to this, great discussion is it kind of matters what size the tube is too, right? So like if somebody has no cuff leak, but there's like an 8.0 tube in there, that's kind of expected, right? You jammed a giant tube in there. If somebody has no cuff leak and they've got like a 6.0 tube, that's a different story.
Bigger
so
deal.
I always sort of contextualize, the lack of cuff leak based on the size of the person and the size of the tube.
Yep, absolutely. All right, so we got a bunch of other cases, and we'll kind of go through these. There might be a little bit of rapid fire action at the end.
Love it.
Next case I'll give you, Nick, is let's say you got a 25-year-old who's intubated for seizures. They're now controlled, but he is unable to pass his SBT. He's got tachypnea, and he actually looks panicked.
Okay.
How would you approach that?
So the goal of a spontaneous awakening trial is that somebody should be awake enough to protect their airway and allow you to assess their breathing mechanics. It does not necessarily mean that they need to be completely off all sedation. And so just like you said before, Cyrus, sometimes the key is coaching them, reassuring them, having family present, soothing words, but sometimes they also need the right balance of sedation and analgesia. So like having them on dexmedetomidine or ketamine can be very useful. Occasionally other meds are useful. So if somebody is having, if somebody needs like a low dose of quetiapine or clonidine, sometimes you can use those as well. Finding the right balance and dialing it in is often the key to success in these people who are failing because of anxiety or agitation.
And I think it's important to remember too that, being on a mechanical ventilator is not normal. And there are some people for whom that's just like a really horrible, very difficult experience for them to tolerate. Often the same folks that maybe have issues with claustrophobia, using their CPAP, for diving, snorkeling. And that in and of itself can sometimes be a reason for this dyspnea. So little tricks can be trying to blow a fan on their face, using high flow nasal cannula, even while they're intubated, just to give them that sensation.
Just a study this week on this, which is really cool.
Oh,
yeah.
Cool.
I mean, yeah, the dyspnea is not just air in your lungs, right? It's also like the sensation of air on your face and your nose and your mouth. And so sometimes little things like that can make a big difference.
Yeah. And other things too, just like trying to distract the patient, have family available, put on a TV or talk to them. Coaching is not just telling them how to do it. It's also supporting them.
Yeah, exactly. What you're really trying to see is like, okay, if I can calm them down and they look okay for a few minutes, we can get this tube out. And so, use all the resources at your disposal. Now, occasionally that won't work. You'll encounter somebody who kind of has two speeds, right? Somebody who is asleep or agitated. Sometimes this is because you failed to treat an underlying cause of anxiety or pain or withdrawal or delirium. Sometimes it's a failure to coach them. There's a lot of other things you can do too, like, are they wearing their glasses? Are they wearing their hearing aids? Are you speaking to them in their native language? Is somebody familiar present? All of these things can help. But sometimes, even if you do everything right, the person is just going to look really uncomfortable. And sometimes I sort of, think to myself, like, how do veterinarians extubate lions and tigers?
Ooh, that was a hard left, buddy. I don't know. How do they do it?
The answer is through a fence.
Oh,
So,
naturally.
the point is they don't wait for them to be fully awake, right? What they do is, like, if a tiger or a lion has surgery, they put them in their pen, they deflate the balloon, they stop the sedation, they tie a rope to the endotracheal tube, and they leave the pen holding the rope. And then once the tiger's kind of awake and moving around a little bit, they pull the rope. They don't have to wait for the tiger to be following commands to extubate it, right?
Ugh.
And so sometimes, you see a similar approach in people where, like, you kind of extubate them, you stop the sedation and they're still a little bit sleepy, but you think their mechanics are good, and you're like, okay, they're going to wake up once this, they're going to wake up now, essentially. Maybe one sort of final note here is that sometimes perfection is the enemy of good, right?
Right.
If the person was intubated for a mental status issue, and that they can wake up, but they're really panicked when they do, sometimes you can be a little forgiving of bad lung mechanics and just say, okay, this is not a physiologic problem with their ability to breathe. This is just a, psychological discomfort with being on the ventilator. And we can, even though they're not quote unquote passing, we can still sort of, round up and extubate them. Obviously, this comes with some risk of reintubation, but that's just par for the course.
I love it. All right, Nix. You have another case for me?
Absolutely. So, 68-year-old man who's in the ICU for severe pneumonia complicated by ARDS. He's been on mechanical ventilation for 12 days. Over the last week, sedation has been minimized. Ventilator settings have been gradually weaned. Currently, he looks kind of weak. He's struggling to lift his arms against gravity. He can barely squeeze your hands on exam. And despite, doing okay on SBTs, there's concern that this patient is not going to be able to adequately ventilate and clear secretions once they're extubated. So how do you approach this situation? What are you thinking through?
That's a great case, Nick, and that's something that's a case we could often see in our ICU. I want to focus on the strength element here and say, basically, there are a couple things you can do. So you can do functional strength assessments at the bedside. There are a number that you can use. There are some hand grip testing skills or hand grip testing tools you can use. You can use the MRC muscle scales to basically objectively quantify muscle weakness prior to extubation. An ounce of prevention is worth a pound of cure. So early mobilization, that's something, we really should be using. We talked about that again with Kaylee Dayton earlier this season. And other things, if this person's kind of maybe just barely passing an SBT, but you really feel like they need more time, you could do some respiratory muscle training. So you can work with your respiratory therapy staff to maybe do some work while they're on the ventilator to actually make them work a little bit harder. And this is, again, not in the throes of illness, but this is really on the precipice of extubation, just to sort of like maybe do a little bit of conditioning type work with them. Not a lot of data here to drive that approach, but it is something you can do. And then the other thing I was going to mention is kind of optimizing nutrition. And we talked about this again with Dr. Wishmeyer, is making sure those folks are getting appropriate protein, essential amino acids, et cetera, during the course of their illness and even beyond, as they're pending extubation, to really try to make sure you're doing everything you can to support them. Nick, anything else you kind of think of in these cases?
I mean, I want to know, does this person have a cough? If they have a cough, chances are they'll be able to deal with secretions. We can talk more about that later. Another big thing in this case is, like, maybe we should extubate them to non-invasive. This is maybe somebody who's going to need a fair amount of non-invasive support coming off the ventilator, where, their diaphragm is weak and they're going to need help to breathe, but they're not going to get stronger on the ventilator. So I'd kind of, err on the side of extubate to non-invasive and, give them a trial of that. In some cases, people in the situation are going to need a tracheostomy. That's fine. That some people will need that. And that is a weaning strategy. Usually, as a personal practice, I like to extubate people to non-invasive and see how that goes before going down the trach route.
Yep.
Because sometimes people surprise you. Sometimes they do better than you think they will. I also think that, there's a lot of psychosocial aspects here too. This is often stressful for the patient, stressful for their family. The family can get very wrapped up in whether somebody's failing, whether they'll ever come off or not. And I just like to normalize it and say, look, this is something we're going to assess every day. It may not go great today, but maybe it will tomorrow. We're making progress every day. And this is another reason why I don't like the summative, like, failed or passed, but like, oh, they went for 20 minutes today. Yesterday, they only went for 10. You can sort of use how long somebody is breathing on an SBT as sort of an endpoint that you're making progress with.
That's awesome, Nick. So kind of dovetailing that with another case, we talked about the weakness or focused on the weakness element. Now I want to focus on the secretions. So let's say we've got another patient, Ms. Garcia, 55-year-old lady. She has COPD. She's here for an exacerbation, and she required invasive mechanical ventilation for 8 days. Her respiratory parameters have improved. She's doing better on the vent. She still has some copious thick secretions that require frequent suctioning, some audible secretions in the endotracheal tube, despite, basic sort of airway clearance techniques. We've got a patient now, the SBTs, again, they're reassuring, but Nick, there's still significant concern that maybe this patient's going to have trouble managing their secretions after the tube is gone. So
Yeah.
what can we do here?
So a couple of questions first off. So if somebody's got a lot of secretions, my first question is, where are they coming from? Are they oral secretions or are they from down the tube? Because obviously those are going to have different issues, right? If somebody's got a lot of like oral secretions, sometimes like something like a scopolamine patch can sort of dry out those secretions and help. If the secretions are coming from her lungs, we're suctioning them out. That's a different approach, and then you sort of wonder, okay, like, is this somebody whose COPD is adequately controlled? Their exacerbation, are they having a lot of purulent mucus because of that? Are we just not at the end of their exacerbation?
Right.
Um, Other things to think about, like, how is their cough? Somebody who's got a lot of secretions, but who's got a really good cough, you know, arguably their cough is going to do a better job of clearing those secretions than I can with a suction catheter. So use their cough if you can. There's other things we can do to sort of help out their cough. So, aggressive sort of chest physiotherapy, sitting them up, chest PT can help sort of mobilize secretions. In some patients, mucolytic therapy can be helpful. So you can give things like hypertonic saline or N-acetylcysteine to sort of break up really thick secretions. I don't use those very often. I know some people really like them. I think the evidence is kind of equivocal. But I think, the key thing here is, asking yourself, like, where are these secretions coming from and what can I do to help, and if they have a good cough, maybe that's what they really need, to do the clearance themselves.
Yeah. Yeah, I think to kind of build on that, this might be another time when that cuff leak test could be helpful just to get a better feel for how bad the secretions might be. If the person's got an intermittent cuff leak, that might tell you that they're just intermittently dealing with a lot of endotracheal secretions. And that might turn you on to some of the things you discussed, Nick. And then making sure that you're watching those patients after extubation. Unless the secretions are really just like rip roaring and impossible to control, a lot of times for me, that's not going to be enough to keep them intubated, but I am going to keep a close eye on them. So monitoring them, making sure that they're getting, continued airway clearance, because that doesn't stop once they're extubated. And then once again, we talked about high flow nasal cannula and non-invasive before. In someone who's got a ton of secretions, I might be slightly more hesitant to use a full face mask non-invasive, but maybe high flow nasal cannula or even like maybe a nasal PAP or something like that could be helpful. Also, giving that patient some additional humidification through a high flow could be helpful to move those secretions along. And then we definitely want to be mindful too, once they're extubated, of doing good bedside, and then if needed, video fluoroscopic testing to make sure that swallow function is intact, or if it's not, we need to make appropriate modifications to that patient's diet so that they're not at an increased risk for aspiration.
And one minor point I'll add on here, which is, this is somebody who's got COPD. If they were smoking when they came into the hospital, they've de facto quit now for a few days, right? And important to remember that when people quit smoking, their sort of mucociliary function recovers after a few days, and that often increases the amount of secretions, right? That's normal, right? That's a normal part of when people stop using nicotine. And so, don't pathologize something which is normal, right? Like, it's actually a good thing. This person hasn't smoked for X days, like, we're going to support them through it.
That's a really great point, Nick. I'm glad you brought that up.
All right, here's another case that we see sometimes, which is like the person who wouldn't want to be reintubated. So let's say you have somebody, 75-year-old, they were intubated for respiratory failure and then extubated and then reintubated. And, the family is pretty adamant that you know, that if the tube comes out, they wouldn't want it back in after this whole course. Do you how do you approach this differently? Is this kind of higher stakes because you couldn't reintubate them?
Yeah, in a sense, I think it is. For me, and this is something we've talked about on the show a lot, but communication is key. So expectation management and explaining to the patient and family, look, this is, let's say, to make it even more complicated, let's say this is a patient who is at higher than average risk for needing to be reintubated and they don't want to be reintubated. I think it's incumbent on us as the healthcare team to make that abundantly clear to the patient and the family, to review and confirm goals of care. Make sure, again, we have to be mindful of our healthcare system. So make sure that that's all documented also, in case things were to go south. But recognize that keeping the patient intubated because you're worried about extubating them since they wouldn't, accept the reintubation is essentially the opposite of what they clearly are indicating, which is they don't want to be intubated. So I would say if that patient is appropriate for extubation, I would want to make sure to have a very careful, deliberate discussion with patient and family to try my best to set them up for success after extubation. But I wouldn't really have any qualms over extubating them if they were appropriate for extubation. Maybe I'd put that person on non-invasive like we've discussed before or something along those lines. But Nick, that's kind of how I would approach it. I don't know if your practice
Absolutely.
changes.
No, I agree. If someone wouldn't want to be reintubated, do you really think they want to stay intubated?
Right.
I mean, it's kind of like, sort of literally following what they say as opposed to sort of understanding why they're saying it. So I think this is a situation where obviously you want to set them up for success, diuresis, extubating, to high flow or non-invasive. But yeah, I mean, just get the tube out. If they don't want to be intubated, let's get the tube out.
Yeah, no, I think so. Okay, great. Let me give you a case, Nick. I want to hear what your thoughts are on this one. So let's say we've got a 75-year-old intubated for an aspiration pneumonia. We tried to extubate him once, didn't go so hot, got reintubated. We're doing our next SBT, and let's say he does okay. We extubate him, and then we have to reintubate him. So he's failed twice now, and so he's intubated. And we're kind of trying to decide what to do at this point in a patient whom, we've been unable to extubate despite 2 attempts. Because again, we don't like that term, failed extubation. So what do you do with this? How do you approach this?
Yeah, so this is tough, right? I mean, I think, it kind of depends on why did they fail and kind of when did they fail. So let's say somebody, they failed minutes after extubation. That's kind of a bad thing.
Right.
That's not great. Compare that to somebody who maybe failed after a few days. That's kind of a different story. That's almost like you wonder, was this even the same problems or did something else happen? So, I mean, you got to contextualize it with the details of how did they fail? What was the timing of failure, et cetera. Another question. So, I mean, we failed twice, sometimes the answer is try again. Sometimes, third time's the charm, sixth time's the charm.
Right.
Keep trying. And I think that's reasonable, I mean, especially if the prior 2 reintubations weren't a big deal and it was done safely and easily, the harm is relatively small if we have to reintubate them a third time. But sometimes you are understandably nervous about this. And sometimes, they've failed kind of precipitously both prior times, and you're like, I don't know if this is the right move. This is a situation where it's often worth having a conversation about, would tracheostomy be a better strategy to get them off the ventilator?
Agreed.
Obviously this is a whole episode in and of itself, so we're not gonna talk about all the nuance of it today. But I think it is a situation where we should talk about goals of care. We should talk about tracheostomy and sort of think about, would that be a safer strategy in somebody who's failed multiple times?
Right. I agree with all of that. I think if this is someone who, we've tried several times and been unable to successfully extubate them, I would probably consider doing like a straight up CPAP trial on this person to sort of, and maybe even let them go for a little while longer, maybe 60 minutes, just to sort of like increase the threshold for success. Because I really, if I'm going to try to remove the tube a third time, And for me, I'd really like to feel a little bit better about it, as opposed to the last two.
Yeah.
I think if they make it through a harder test, it increases my pre-test probability for a successful outcome. The test in this case being another extubation. And then, yeah, like, having that discussion of tracheostomy, being ready to extubate directly to non-invasive. I think that's all very good. And yeah, I think actually in our next case, we might get into that strategy of non-invasive in a little more granularity.
Yeah. Great, great. Yeah, I think that's a perfect discussion. So, okay, another lightning case for you. This is a let's say a 55-year-old man with heart failure who is intubated as part of a heart failure exacerbation. Now he's a couple days into his course. His cardiac output is supported with inotropes and devices. He's doing a little better, and he's passing an SBT. So, should we just extubate him, or anything else you want to think about in this guy?
Yeah, so there's actually, I think, a lot to think about. So you mentioned this before, Nick, this idea of a zero peak trial or a ZEEP trial to sort of make sure that they don't develop flash pulmonary edema the minute you take away that positive pressure. So I think that's a reasonable thing to think about. I would probably do a good ultrasound assessment of that patient, a good physical exam, see kind of where's their volume status at. If I have a central line, I can get a CVP. I can add that to my sort of calculus. If I have a SWAN, even better. And then this is, again, another patient where I would think about using non-invasive positive pressure ventilation. And especially if it's someone who's got both cardiac and pulmonary comorbidities, and older patients as well, definitely great candidates. And remember that positive intrathoracic pressure can help the LV, it can hurt the RV, but it can help the LV. And so if we're dealing with that flavor of heart failure, maintaining positive pressure in the absence of an endotracheal tube is great. Now, I feel like we've been burying the lead here, but where does this come from, or what's the most recent data from? So there was a study, I think it was a JAMA study called Weaning. And in Weaning, they took 641 high-risk patients that they essentially defined as being elderly or having a history of cardiopulmonary disease, that were in the ICU, and they randomized them to being extubated to high flow versus extubated to a protocolized combination of high flow and non-invasive, basically providing as much non-invasive support as reasonable in the immediate post intubation.
But giving them kind of breaks with high flow, which is a great kind of hybrid. Yeah.
Yeah, exactly right. And what they found was in this population, the high flow plus non-invasive strategy significantly reduced the risk of reintubation in these high-risk patients. So that's kind of where this practice is coming from that we've been talking about, and why I use it a lot myself in my ICU.
Yeah, I think that's great. I mean, if somebody's got a ton of B lines, their oxygenation status is tenuous on the vent, I think it's good to be really aggressive about extubating to positive pressure, just like in high wean. And I love what you said too about like the, are you diuresing them enough? One other minor point to add is that, you mentioned that the intrathoracic pressure can enhance forward flow of blood. Sometimes these folks need more inotropes after extubation. So sometimes you've got them dialed in on their support, and then you extubate them and you have to kind of reevaluate what their needs are. So just an added layer.
Awesome. So let's finish this out. It's like a pizza, 8 slices, 8 cases. So let's gobble up that last slice here. Let's talk about self-extubation. So perhaps we have, a 24-year-old patient who was intubated in the emergency department for acute alcohol withdrawal, or maybe let's not say withdrawal. Let's say they were acutely intoxicated. They were a threat to themselves and others. So they were, intubated for protection of self and others. And,
Protection of airway, maybe too.
Sure. Yeah. That's also kind of important. So let's say the dust is settled, everything's looking good. And we're starting to think, okay, let's get things together and plan our extubation strategy. And all of a sudden you get called to the bedside because that tube came out per patient with the cuff fully inflated. What do you do?
Yeah. Yeah. Okay. So, self-extubation's not ideal, right? Obviously, I'd like to be in control of extubations, and, it's not going to feel great to yank out a tube without deflating the cuff, right? There is potential for significant, like, vocal cord trauma from that. But it's also important to recognize that most patients who self-extubate will do just fine, right? If you are with it enough to self-extubate, you're clearly strong, you've got some degree of coordination. And so by the numbers, only about 20% of people who self-extubate will require reintubation within 24 hours. I think it's really important to figure out if you're looking at that 20% though. So you get to the bedside, do they have stridor? Do they have a really weak voice? Are they awake and following commands, or are they completely obtunded and they just had one moment of coordination? You know, Also, just how is their gas exchange? So if they're oxygenating okay, on ambient air or on a nasal cannula, that's a good thing. If they're hypoxic, that's obviously a bad thing. I think there's assuming that they're doing okay. So assuming that their gas exchange is all right, they're awake, and they don't have signs of significant airway trauma from doing this. These are people who, in general, you can just watch closely, but it's very important to recognize that a subset of these patients are going to need to be reintubated right away. And many of them, the trauma of pulling out the tube can make that a bit of a spicy reintubation.
And we're going to talk about that in a second. But before I get into that, this kind of reminds me too of this idea of the preparation to extubate, or the approach to extubation strategy can't really be one size fits all. So in a patient like this, we talk about colloquially pull and pray, so to speak. This might be a patient who I'm not, under circumstances where we're actually going to deliberately extubate them, I may not be particularly concerned with going through every single step we discussed to a T, because I know that they were intubated for a short period of time for a very particular reason. They have no underlying cardiopulmonary disease. There's someone who I can basically, quick trial, make sure that they're okay, give me a thumbs up, remove the tube. Those are the same kinds of patients that typically, if they do self-extubate, they tend to do better. Now, if you instead are dealing with someone who maybe is in the throes of their acute disease process and they are delirious and they self-extubate, it's a little bit different. And that's when I think, Nick, you were getting to this idea of that reintubation could be dicier. And I totally agree. And so I would say by default, if I need to reintubate a patient like this, I'm considering it a difficult airway, because that's going to kind of alert the team to, okay, got to be on our A game. We got to have all our tools ready to go. We might want to have an additional airway operator kind of in the area just to be safe. And so typically what I would do to get really granular here is I would grab an ET tube about 1 to 2 sizes smaller than the original tube. I would definitely use video laryngoscopy, which I think we sort of like know from the device trial and other trials that that's pretty much the way that we should be proceeding.
If you're not using VL in 2025, you should be,
right,
rethinking your practice, I think.
Right. I totally agree. So this is certainly no different. If you go in there and you've got, again, standard geometry blade, and all of a sudden it's a contaminated airway, where there you go. Now you're back to a standard MAC. And again, in the same vein, I probably want to have a bougie on board. Whether or not the airway becomes contaminated, I might have a very small opening, and I might have to thread that bougie into the opening as a means to kind of get the tube in place. And that's, once again, a time when a smaller tube would be helpful. And having a supraglottic airway on hand too is not a bad thing either. So that's what I would kind of say as far as that goes.
Great points. Yeah, I'll add 2 details. One is when we were outlining the assessment, like step 1, look at the patient, step 2, look at the monitors, step 3, ventilators, step 4, blood gas. We didn't really say step 0. Step 0 is underlying illness. Are they getting better? Are they better? And so this is somebody where they are better. So that it's an important context, right? Somebody who self-extubates, who's very, very sick, is a different story. Another point that I would make too is often when you get called about a self-extubation, the most important thing you can do is to stop the drips. So maybe they were on some drips and they self-extubated, and in all the chaos, people don't realize that there's still like propofol and fentanyl running. So, they are going to fail if you don't stop those.
Great.
So be sure to do that.
Awesome. All right. So guys, we've spent quite a while here discussing all things extubation, really from soup to nuts. Hopefully this was helpful. And I know, again, our audience was waiting on this, and so I'm glad we could deliver. If you want to learn more, please check out our show notes on the website, www.criticalcaretime.com. While you're there, you can subscribe to our mailing list, leave a comment, or hit up our store.
Yeah. And now we're at the part of our episode where we like to say thanks. Big thanks to everyone who's left us a 5-star review. You're awesome. I am giving you a 5-star review for doing that. Huge thanks to our CCT team, Kurt Belknap, who's the composer of the theme song you're hearing, and the folks over at Podpaste for their amazing editing skills. I have a special request for listeners this week, especially all those people who have left us 5-star reviews. We love you. This week, if you could share the show with a friend or a colleague, help other people discover the show by saying, text, check out this awesome show. We'd really appreciate it.
We sure would. And also, in the spirit of giving thanks, we, of course, want to give a big thanks to our sponsor, C-Star Medical, who have supported us here in Season 2 of Critical Care Time. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
We should say that the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters are completely made up, fictional. They're totally HIPAA compliant. Any similarity to real-world cases is just because we're amazing fiction writers. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thank you so much for listening. We really appreciate all of you fans. I am, once again, Dr. Nick Mark.
And I'm Dr. Cyrus Askin. All the best to you all, and we'll see you next time.